Today, Dr. Sreedevi will be talking about nausea and vomiting. So this is a very important topic because you might have seen many patients are presenting with nausea and vomiting. Mainly cancer patients, but there are many other patients who also presents with various forms of nausea and vomiting due to multiple etiologies. So now there is a tendency to prescribe ondansetron for whatever be the type of vomiting. The ondansetron is the drug of choice, and we actually need to understand what is the mechanism of nausea and vomiting, and the pathways involved in this nausea and vomiting, and what are the medications by which we can relieve nausea and vomiting. So today's session will be handled by Dr. Sreedevi Warrier. Dr. Sreedevi is a palliative care physician at Pallium India. She has done her MSc in palliative medicine, and she has more than 5 years of experience in palliative care. So welcome, Sreedevi, and it's over to you.
Thank you, sir, for introducing. Thank you, everyone, for joining. As Dr. Sunil was mentioning, today we'll be talking about nausea and vomiting, and we'll understand the various pathways involved and how can we decide on which medications to be given, how to assess nausea and vomiting. I have tried to keep it as simple and as explanatory as possible. So you can interrupt me or you can type in the chat session in between if you have some inquiry in the slides or the explanations that I give you. So today we'll start the presentation. So why should we talk about nausea and vomiting in the first hand, especially in a palliative care setting? Because we know that not just pain, we deal with many other symptoms, which are symptoms that affects the quality of life of the patient, even the daily functioning. So we know how important it is to control these symptoms. Otherwise, the patients are already sick and going through a lot of trouble in terms of physical issues and psychological, financial issues, the treatment-related problems. So we need to control all the symptoms as much as possible. So what happens when the patient is having an uncontrolled nausea and vomiting? They'll have difficulty in taking medications, or sometimes they'll be scared. A small example would be the moment we hear about cancer chemotherapy, everyone will be scared about either hair loss or vomiting. So the vomiting is a really dreadful symptom to many, and most of the time the non-compliance to many treatment may be due to poorly controlled symptoms, which includes nausea and vomiting, because they'll be scared to take the medication. What if I vomit and I don't want to go for chemotherapy? Inadequate symptom control, because many of our patients will be on oral medications so that it is easy to control at home. But then what happens if they have uncontrolled nausea and vomiting? There is always a fear of poor absorption. I have vomited all the medications out. Or sometimes we actually experience poor pain control, because a patient with nausea and vomiting will vomit out all the tablets. For example, they might be on morphine, and then they'll have increased pain. So the symptom control is totally affected when there is a poor control of nausea and vomiting. And there will be huge amount of distress among the patient as well as in the family. Because when your loved one is vomiting in front of you, unable to eat or drink anything, then the family gets really distressed, because he's undergoing a lot of treatment, a lot of medications he's taking, but he's unable to eat because of nausea and vomiting. So it is always a reason of distress among the patient and the family members, because it's very difficult to see someone keeping on vomiting all the time. And very often our patients will tell us that they are not eating because they have this nausea, the feeling of vomiting. Although they don't vomit, they just don't eat anything. And what is the prevalence of nausea? How common it is among palliative care population? This is purely from a palliative care view. So we can see 6 to 68% of patients with advanced cancer will have nausea and vomiting. And we can also see this nausea and vomiting is not just confined to people with cancer. See, because the moment we hear about pain, nausea, and vomiting in palliative care, suddenly we think about the cancer patients. Okay, cancer related vomiting or cancer related pain, cancer related nausea. No, it is also seen very commonly in patients with HIV AIDS, in advanced stages of heart disease as well as in renal disease. So it is not just cancer we are talking about here. We are talking about many other illness, especially during the end stage. We'll have a high prevalence of nausea and vomiting in palliative care patients. So what are the objectives of this treatment? What are we looking forward to? We try to reduce or at least we try to stop the nausea and vomiting, but at least to reduce the frequency of nausea and vomiting. And once you are able to control the vomiting, then the patient will be able to take oral medications at home. Otherwise, they have to be admitted in the hospital setting all the time, right? To give injections, everything. They can't be at home. So once we control the nausea and vomiting, the patient will be able to take the medications orally, and they'll be happily going for the treatment because they know that their nausea and vomiting can be controlled. I can be nausea or vomiting free even if I am undergoing chemotherapy. So it improved the compliance to the disease modifying treatment. And without any question, improve the quality of life. When the patient is happily eating or not having any nausea, at least the family members will feel totally comfortable because they are able to feed something, give the medications on time. So these are the main objectives that we are looking for. So these are some of the definitions so that we can differentiate between all three. The patients will tell you very vaguely about all this. So we need to be sure what we are dealing with. So three main complaints will be either nausea and vomiting together, nausea without vomiting, retching. So you can see various combinations of these complaints. So we need to know what we are talking about. So nausea is an unpleasant feeling of need to vomit. The patient may not actually vomit out the contents, but he will have the feeling of vomiting along with symptoms like pallor, he will be colds, salivation, sweating, the tachycardia, everything will be there. They may not actually bring out the gastric contents. It is just a feeling, unpleasant feeling of need to vomit. And the second one would be vomiting. Vomiting is the forceful expulsion of gastric contents. They bring out the gastric contents outside. It is not just a feeling, but the gastric contents are coming through the mouth. The third one is retching. This is also very common. Sometimes patients tells you they are having vomiting, but when you ask again, you can see it might be retching. Retching is a rhythmic, labored, spasmodic movement of the diaphragm. So they feel like after they eat, with periodic movement, something is coming up to their oral cavity. They may not actually vomit. They may not have any nauseating feeling, but there will be some. They have the feeling of something in the throat, coming up to the throat feeling. And you can learn your own language, local language, because people use different language for expressing nausea, vomiting, and retching. So it is very important to understand what language they use in your place. So how do we manage? What are the principles of managing nausea and vomiting? The first focus for any symptom management, whether it is pain, whether it is nausea, constipation, any symptom management, the first priority is correcting the cause, correcting the correctable. Think why this patient is vomiting, or if it is pain, where is this pain coming from? What can be the reason? Whether there is a nerve compression. So in case of vomiting, what can be the pathway involved? Is there any medication that can cause vomiting? Is there diet is causing vomiting? So understand what can be the cause. That is the primary thing in any symptom management. Along with the pharmacological management, we should always focus on non-pharmacological measures. We should think about how to control vomiting as much as possible with dietary modifications or non-pharmacological measures. And the very important part in today's session would be blocking the receptors at various sites. How to use an appropriate antiemetic, not just any antiemetic, as Dr. Sunil was mentioning. There is no one antiemetic which suits for everyone every time. So we have to understand first the cause of vomiting. Then, along with medicines, you have to try non-pharmacological measures, and understand what are the sites, various centers involved in vomiting, and block the receptors at various sites. What would be the non-pharmacological measures that we can tell the patients? Very simple ones. Avoid situations which induce nausea and vomiting. Very often patients will be given, which I have seen, patients will be given a lot of protein supplements or many drinks so that they improve their general condition, and that itself will induce nausea and vomiting for them. So there must be some particular food or smell of food that they may not like. If possible, avoid such situations which can actually produce nausea and vomiting. Next thing would be good environment and fresh air. In many homes, when you go for home care, they would be crowded or unhygienic, or there won't be any fresh air, unclean clothes. They might have vomited, and the vomiting tub or the basin would be kept just near the patient. So by looking at it or even smelling it, they will start vomiting again. So make sure that the environment is clean, which includes a good wound care also. Suppose the patient is having a colostomy or a wound over the body, and there is a foul smelling, the wound is very foul smelling, then that itself will be a reason for nausea and vomiting. So just look at the environment, if possible, keep it clean, and make the patient lie down so that they get some good fresh air. And the last portion, there is a tendency that when the patient is lying down, we try to feed them without placing them in upright position. So tell the caregiver, at least with 2-3 pillows support, just try to nurse in upright position, not on lying down position. Because when the patient is sick, they tend to feed the patient while lying down. That should be completely avoided. So these are the simple measures that we can tell the patients to follow at home. This is nothing that is difficult to follow, right? So these are the simple things. Again, good oral hygiene. Any symptoms, I say including pain, it's a very good practice, and it is a very important practice to look at the oral cavity. Because any signs of oral thrush itself, it might be the single reason for nausea and vomiting. So good oral hygiene is a very important thing. And suppose a patient was vomiting continuously, we should definitely check the oral cavity to check whether he is dehydrated. So check the oral cavity when the patient is telling all these symptoms. And as I mentioned, control of the foul smelling. They may have a colostomy bag, they may have a foul smelling ulcer, a fungating ulcer, a bed sore. So that itself can induce nausea and vomiting. And if possible, we can ask them to use suitable distractors, like if they want to listen to music or watching the television, that can be encouraged. We cannot emphasize much on dietary modifications because our patients will not want to eat much, right? They'll be so tired. They'll be having anorexia, cachexia. So they won't be able to follow all the instructions, but we can always tell all these simple steps, small frequent meals. So we have a tendency to eat like 3 meals a day. Tell them not to stick on to that 3 meals a day protocol. Take a small 1 or 2 spoons or 1 or 2 sips every now and then. So the total input will be better rather than just keeping it for 3 times a day. Tell them to eat 2 spoons now. After 2 hours, another food item, 2 spoons. So altogether, they might have got whatever they want. And if possible, tell them to avoid carbonated drinks. They have a tendency, I've seen in many patients who would like to drink Coke or any carbonated drinks when they have nausea and vomiting. They feel there is some relief when they drink that, but that might end up in more trouble. And usually they tolerate bland food and clear fluids, because you might have seen patients will be happy to take rice gruel or tender coconut water. So it's bland food and clear fluids they tolerate much better than the spicy or sweet or sour foods. So these are the simple dietary modifications which any patient can follow. And this should be communicated well to the caregiver, because the caregivers will always have a tendency to feed. And they may tell you that the patient is not eating anything. But when you ask, they might have eaten 1 idli or half dosha, and that is fine. That is enough. After 2 hours, they will be full. first you can tell them to have a half idli more maybe. So altogether the intake will be much better. So next we move on to the pharmacological measures. I'll be talking a lot about receptors and the centers. You might feel it quite confusing in the beginning, but when you try to read again and then start applying it to the patients, then you feel it is much more, it starts making more sense. So this might be slightly confusing in the beginning, especially when I'm talking about a lot of receptors. So important things that we need to remember, there are 5 key players in this show. When you are dealing with nausea and vomiting, these are the 5 players that you have to remember. The first one would be the important part is vomiting center. All the 4 sub-players, the important player in this game would be the vomiting center, and the 4 other supporting players would be CTZ, that is a chemoreceptor trigger zone, and receptors in the GIT, receptors in the cerebral cortex, and in the vestibular nucleus. So altogether, the vomiting center is the boss, and the other are the other 4 players which help the vomiting center in this play. So 5 centers we have to remember very thoroughly, then only we will be able to connect what I am telling. So we'll talk a little slightly in detail about each center. The first center is vomiting center. So we know that it is located in the medulla and it is a final common pathway for all other centers. And it is an interconnecting neural network. So it will integrate all the vomiting stimuli from with the parasympathetic and motor efferent activity and will produce a vomiting reflex. You don't have to remember all the details, but just to remember that it is a final common pathway for all the vomiting other vomiting pathways. The second thing would be chemoreceptor trigger zone. You might have heard a lot about chemoreceptor trigger zone. Why? Because all the chemotherapeutic agents will induce vomiting through CTZ, or many of the drugs in the blood will act through the CTZ. Why? Because it is positioned outside the blood-brain barrier. The CTZ is positioned outside the blood-brain barrier, so it is accessible to many emetic substances, either from the blood or in the CSF. So it is a very important center regulating many of the vomiting that we see in day-to-day patient care. So I would say an example would be chemotherapy. The drugs which cause vomiting would be acting at the chemoreceptor trigger zone. In the blood, it will reach the chemoreceptor trigger zone because it is placed outside the blood-brain barrier. So next is the proximal bowel or stomach. There we have a lot of receptors and which will stimulate the vagal and splanchnic afferent fibers within the bowel wall. And this will give signals to the brainstem directly or through the CTZ. So either they will send directly to the vomiting center, or they act through the CTZ, causing the emetic nucleus. So the first one was vomiting center. We talked about vomiting center, which is the final common pathway. The second was CTZ, where all the blood and CSF related drugs or the chemicals will act. The third one was stomach or proximal bowel wall. The fourth one is cerebral cortex, where you have a memory or fear or modification. So I'll tell you an example. A patient who had severe vomiting with the first dose of chemotherapy. So next time, the date has given for the next chemotherapy. So previous day itself, he'll start having the memory or fear of vomiting because he had severe vomiting last time. Or you might have vomited taking a particular food. Next time when you see the food, you have that memory, yeah, last time I have vomited because of this, I'm scared of vomiting. So those kind of higher thinking is happening through the cerebral cortex. So it is mainly deals with the memory, fear and modification related vomiting. Vestibular nucleus, we all know it is concerned mostly about balance and movement related nausea and vomiting. So these are the 5 centers that we need to deal with. Clear? So now we will see the various receptors. Now we have seen 5 centers involved in nausea and vomiting, and now we will see various receptors involved in nausea and vomiting. The important ones only. The first important receptor would be, or neurotransmitter would be dopamine. Dopamine is very familiar to all of us, right? There are 5 groups, D1 to D5. We are concerned mainly about 2 things, D2 in the CTZ and D3. So we just need to remember D2 and D3 for today's purpose. We have 5 dopamine receptors, but we are thinking about only D2 and D3. And D2 is seen in CTZ as well as in the GIP. Next would be serotonin. And again, they have 4 different groups, 5-HT1, HT2, HT3, and HT4. There are 4 types of serotonin receptors. And we are concerned mainly about 5-HT3 and 5-HT4. Okay. So dopamine, we are looking at D2 and D3. Serotonin, we are looking at 5-HT3 and 5-HT4. And the next minor receptors involved would be substance P, neurokinin A, B, 1, 2. And so basically they are grouped into tachykinins and neurokinins. They are usually seen in the central nervous system and also in the CTZ and also in the GIP. So distributed almost everywhere. And there are other minor neurotransmitters like histamine, acetylcholine, endorphins, GABA. So today we'll be focusing mainly on dopamine and serotonin, and we'll be talking about other drugs which acts at the tachykinins and neurokinins. So this is a picture which you can it is just a compilation of all the centers and the receptors and some examples of how we can relate everything together. You can look at the so you can look, first we start with the emitting pattern generator, vomiting center. So what happens in the vomiting center? You can see there is acetylcholine, histamine, opioid receptors, 5-HT2 and neurokinin. So if you want to block the vomiting center, you have to give the drugs which can block all these receptors, right? So that is how this picture makes sense. Now we can start here, gut wall. Gut wall, what are the receptors in the gut wall? We can see neurokinin 1 is there, 5-HT3 is there. So if you want to block these receptors, we have to give drugs which acts on 5-HT3, which will block the 5-HT3 receptor. So these are the examples above given. For example, a patient is having chemotherapy. Okay, that is a very familiar picture for most of us. So chemotherapy, where does it act? It acts at the 5-HT3. Where are the 5-HT3 here? You can see 5-HT3 is there in the gut wall. 5-HT3 is there in the CTZ also. So you have to give a drug which blocks the 5-HT3 receptors in the gut wall and in the CTZ. See, so when you remember this picture, it would be much more easier for us to deal with the symptom. Now we'll see morphine, another familiar drug for us. So we have learned morphine can cause nausea and vomiting. Where is it active? D2 receptor in the area posterior, right? That is CTZ. So we have to give a drug D2 receptor blocker so that we can control morphine-induced nausea and vomiting. So that is how we can relate all these symptoms. Where is it acting? So this is correcting the correctable. You are thinking where it is coming from, all this vomiting, so that you can block with appropriate antiemetic. So in the end, see movement and vertigo. So we know that it acts at the vestibular nuclei. What are the receptors? Acetylcholine and histamine. So you have to keep acetylcholine blockers and antihistamines, H1 antihistamine. And this is how you can simply remember. It looks quite confusing in the beginning, but when you start seeing patients, suppose a patient is coming to you and telling, I have underwent abdominal radiotherapy and now I have vomiting. You can look at the physique abdominal radiotherapy, probably it's 5-HT3 in the gut wall. So we need a blocker. So you can refer which drug would be blocking 5-HT3. And next is, according to the center, I have tried to classify the antiemetics, which are the receptors in the vomiting center, which are in the CTZ. So now we have heard about 5 centers. We heard about what are the main receptors or neurotransmitters like dopamine, serotonin, etc. We heard. Now we need to know which is where. Receptors, which is where. So then only we can try using those. So the first, we deal with the vomiting center. In the picture we have seen, in the vomiting center, you can see antimuscarinic, antihistamine, 5-HT2 and NK1 receptor antagonist. So anti-muscarinic means we have to block that. That is, we have to give hyoscine. If it is H1 receptor blocking, we have to give cyclizine. 5-HT2, then you have to give 5-HT2 receptor antagonist. So likewise, we can relate. So now we need to know which are the receptors involved in the vomiting center and then give the medicines accordingly. You don't need to by heart all this. It will come along with your practice. Basic things you need to know, but then you start, when you start following this pathway, then it becomes much more easier. Chemoreceptor trigger zone, D2 and 5-HT3 receptor antagonists are we are talking about, and D2 receptor antagonists are haloperidol, metoclopramide, and domperidol. So we have seen in the picture that morphine causes vomiting through D2 receptor. So we have seen D2 receptor antagonists are haloperidol, metoclopramide, and domperidol. So these will be the drugs which will help you to control morphine-induced vomiting. So it is very simple, relating, understanding which is the receptor, understanding which medication is used to block that receptor. Again, cerebral cortex. See, here we have seen in cerebral cortex, we can see GABA, histamine, and neurochymine. Here we have seen GABA. So which are the drugs which we can block this? Benzodiazepines like lorazepam. Cannabinoids are not available in our country, but it seems to have good effect in controlling nausea and vomiting. Corticosteroid again is a wide spectrum with non-specific but wide spectrum antiemetic, which acts in the cerebral cortex level, and neurokinin receptor antagonists like epinephrine. So now this will give you some idea after today's session, and then you once start practicing, then you will get it more clearly. Next class would be what are the types of antiemetics that we use? Prokinetics. You might have heard about metoclopramide when you dealt with morphine session. So what metoclopramide is basically a 5-HT4, primarily a D2 receptor antagonist, and it has also a serotonergic antagonistic action also. I'll just come to one by one in detail, then you will be you will understand how the drug and how it is to be given, where does it act. To make it much more easier to remember, we can talk about 10 N's which can cause nausea and vomiting. 10 N's which you can remember which will cause nausea and vomiting. So when you see a patient, you can think which M is working here, and then accordingly you can choose the medication. The first would be metastasis. Any metastasis to the cerebrum or any cerebral metastasis or liver mets can, cerebral mets can increase the intracranial tension, and in liver it can also increase the capsular stretch, also toxin buildup, can cause nausea and vomiting. So where does it act? It acts at the cerebral level as well as the CTZ. So the drugs involved would be steroids and mannitol. So metastasis, cerebral and liver metastasis can cause nausea and vomiting, and the drugs would be to reduce the intracranial tension. So we can use steroids and mannitol. And there can be leptomeningeal disease, which can increase the intracranial tension. There also we can use steroids. Next, M would be medication. Many medications that we use can cause vomiting. The first one would be opioid. The opioids that we use, around 30% of patients will have nausea and vomiting, which is reversible. And this will act through CTZ, vestibular, and GI tract. So we know CTZ, which are the receptors? Vestibular, we know histamine and acetylcholine. GI tract, we have D2 receptor. So we have to block accordingly. If patient is on opioid, we have to give metoclopramide or haloperidol. Both of them act at D2 receptors. And if it is due to chemotherapy, then you have to give ondansetron or dexamethasone. NSAIDs, we know it can cause vomiting through GI irritation or any peptic ulcer related nausea and vomiting. Then you can give proton pump inhibitor. It has NSAIDs will also act through CTZ. So whenever you hear about CTZ, the drug would be usually ondansetron, especially when it is drug related. Next would be movement. Movement means vestibular. Sometimes we see patients complaining movement-related nausea when they are on morphine. Then the drug of choice would be promethazine. Mentation means thinking, anxiety. They are worried. They think a lot about our memory or fear about nausea and vomiting. Then you would use lorazepam. The next time would be mechanical. That is, there is some mechanical obstruction, mechanical distension. Then you need to manage the distension, obstruction, or constipation, whatever is causing the mechanical issues to the GIT. Metabolic. You know that various metabolic.
Dr. Sreedevi, just want to intervene. There is a disturbance from your end.
Okay. Is it the less voice or from the vehicles moving around?
It's from your voice, ma'am.
Okay, right. I'll keep the mic close. Is it better now?
I think it is. Yes, ma'am.
So, when we talk about metabolic, even in non-cancer patients, we deal with a lot of metabolic causes, right? Hypercalcemia, hyponatremia, or sometimes with liver failure, renal failure. So all these are, any metabolic failure means some chemical imbalance in the blood, which will reach the CTZ. So we have to correct the metabolic issues, as well as we have to give drugs like and some are the motility-related nausea and vomiting. Opioids, we know, will reduce the gastric motility. And there are so many medications which can cause paralytic ileus. So then we need to give something like prokinetic, that is methylpropamide or bisabolol.
And there are a lot of mucosal. Next M would be I think it's the second last M, mucosal. When you give NSAIDs, we know that mucosal erosions happen, then you give antacids. The last M is microbes. Microbes in the oral cavity like candidiasis, microbes in the GI tract like herpes infection, or any other viral or bacterial issues, we have to give antiviral or antibiotics. Now there can be systemic. If it is a systemic sepsis, we know that anything in the blood reaches the CTZ. Then you need to give appropriate antiemetics as well as antibiotics to control the infection. We will go to the management part. Should I continue, or is there any doubt that you need to clarify now? If there is anything in the chat, just let me know, or I'll proceed. So this is the look down for approaching a patient with nausea and vomiting. First is thorough assessment. Asking in detail about their symptoms is very important. Any symptom. The patient will tell you, I have nausea and vomiting, or I have vomiting. Don't just stop by there. Ask when do you vomit? Is it before food, after food, irrespective of food, or only while taking food? What is the volume of vomiters? Is it preceded by nausea? Is it unchanged food or undigested food particles, or is it black color, green color? So you have to ask each and every details in assessment. Is it associated with pain? Is it associated with constipation? Is there any headache? We don't know whether it is a raised intracranial tension. So ask whether there is any headache, etc. And then look for correcting the correctable. As we said, sometimes the wound might be a reason. Sometimes the food might be a reason. So understand which is correctable and then correct it. And then manage the consequence and complication. The fourth point would be provide targeted therapy. Choose appropriate antiemetic. Understand where exactly. This can be called as a mechanistic approach, where you trace back why this patient is vomiting, where this is coming from, which are the receptors involved, and then you are giving a targeted therapy. Then it finds more meaningful. Choose appropriate food. When the patient is vomiting continuously, you can't give oral medications, right? So you need to think whether we need to choose the subcutaneous food so that the patient can be managed at home as well as in the hospital. And give attention to details. As I said, I give metoclopramide and the patient is telling you, I have increased colicky pain. So that is something that we really need to look into. So don't forget to give attention to details. So this is the this thing. Like pain, you have to ask about the quality, the duration, whether it is intermittent, whether it is all the time, how many times a day, associated with pain or altered bowel habit, any smell of food, anything which is worsening your vomiting. Is it just in the morning? What is helping to relieve the vomiting? Everything you have to ask as in pain or any other symptom. Examine the abdomen, check for any hepatomegaly or any masses, or check for the bowel sounds. If indicated, we can always do a rectal examination. Check for any signs of sepsis or any metabolic abnormalities. Check for hyponatremia, hypokalemia, whichever is needed to check whether this is a metabolic reason for vomiting. Do all these investigations. We usually don't need much of the investigation, but might be some of the labs like RFT, LFT, or some of the electrolytes, and quite rarely we may need an abdominal X-ray. So we'll just go through each drugs that we use. Very commonly used drugs only, not all the drugs I'm talking about, just the commonly used drugs in palliative care. The most commonly used drug I would say would be metoclopramide. It is usually used in decreased motility because it is a prokinetic. Prokinetic means it increases the movement. So whenever you suspected decreased movement or delayed gastric emptying, then you can use metoclopramide. As we said, it mainly acts on the D2 receptors. Very important, it acts on the D2 receptors, but higher doses, it has serotonin 5-HT4 receptor blocking action also. It is a prokinetic mainly because it acts at the cholinergic system in the wall of the gut, and that's how it acts as a prokinetic. It blocks the dopamine brake. There is a phenomenon called dopamine brake on gastric emptying. So basically dopamine, in simple terms, I can say dopamine is like a brake on gastric emptying. So gastric movement is happening. Suddenly dopamine is putting a brake on the gastric emptying. So we need to release that brake and put an accelerator so that the gastric emptying will happen again. So metoclopramide will release that dopamine brake so that the emptying is normal. So that is how, that is that dopamine brake concept. And it is bioavailability is pretty good, and duration of action is 1 to 2 hours. Usually we give 6-hourly dose. The one thing you might be scared or you might have heard about would be the extrapyramidal symptom. That is, with any neuroleptic, you might be worried about the extrapyramidal symptom. That is
one thing we need to think about. And you cannot give metoclopramide because it is a prokinetic. We cannot give it in a patient with complete obstruction. And there is a complete obstruction. Any prokinetic you give, you have a tendency to ending up in a perforation. So that is one thing that you need to remember. So caution, it may reduce the seizure threshold. It already in Parkinson's disease, it may exacerbate. It is not a contraindication, just that you have to keep it in mind that I am giving a drug which may rarely cause an extrapyramidal side effect. And if there is a recent GI surgery or complete obstruction, you cannot give any of the prokinetic drugs. So be cautious about giving that. And important point, do not combine metoclopramide with any of the antimuscarinics because one will push the bowel, one will stop the bowel. So there is no point in giving medications at all. So never combine the prokinetic and the antimuscarinic. Next, D2 antagonist. So again, metoclopramide was a D2 antagonist, and next D2 antagonist would be domperidone. It normally does not cross the blood-brain barrier. Raju, is there any disturbance again from my side?
Doctor, it is from your side. We are not able to clearly hear you.
Is the voice very low, or is it some background noise coming?
Background noise coming in.
I'll just stop it. Just give me a second. And it has a dual anti-emetic effect. It acts in the CTZ as well as in the GIT. And again, like metoclopramide itself, it has action on releasing the dopamine brake. It is slightly less undesirable side effects than metoclopramide because it causes drowsiness, etc. And in practical side, I don't think metoclopramide itself causes drowsiness in a practical point of view. Again, the same contraindication, you cannot give, it is a prokinetic drug, it will increase the motility. So you cannot give when the patient is having a GI hemorrhage or signs of perforation. You cannot give in complete bowel obstruction because it will end up in having perforation. it is not known to cause any extrapyramidal side effects as frequently as metoclopramide. Is another class of drug. We know that it is a typical antipsychotic. You might have used a lot of allopurinol for controlling psychiatric issues, but it is also an antiemetic. It is a pure D2 receptor blocker, and the antiemetic doses are really, really low. You can always start with very like 0.5 milligram, or you can start with 1.5 would be usually enough to control nausea and vomiting. Another atypical antipsychotic drug, you might have used it as a psychiatric medication. It is olanzapine, which is a broad spectrum antiemetic, which acts on many receptors. Most of the dopamine receptors, most of the serotonin, histamine, cholinergic. So it has a wide spectrum of action, very effective as antiemetic with a smaller dose of 5 milligram per day to start with, or even 2.5 milligram per day you can start with. The last drug will be levomethomazine, is not available in our country, but it is a D2 receptor antagonist. So people, if there are people from other countries joining for the course, levomethomazine is a very effective antiemetic, very commonly used in blocking the D2 receptors, especially for refractory nausea and vomiting. Of course, you know, steroids play a lot of role. You might have heard in pain management. Again, it is a broad spectrum antiemetic. You might have seen people getting steroids after chemotherapy or in bowel obstruction, raised ICP. So steroids, another very important class of antiemetic. The dose would vary from 4 to 8 milligram per day, or maybe up to 16 milligram per day if it is a malignant bowel obstruction. Raised intracranial tension, the doses might be quite higher, and we use a step-down approach usually. Octreotide is another somatostatin analog, which is very commonly used in bowel obstruction and refractory vomiting. Hyoscine, you might have heard about the tablet Buscopan or injection Buscopan. It is an anti-muscarinic drug. It reduces the GI secretion and reduces the motility of the GI muscles. So that is how it reduces nausea and vomiting. Cannabinoids acts on the cannabinoid receptors. Benzodiazepines usually acts in the central vomiting center. It is an anxiolytic, or it will deal with memory or fear-related nausea and vomiting. The most commonly used benzodiazepine in nausea and vomiting would be lorazepam. Is there anything that you want to clarify before moving on to the next? Is the audio better now? I don't know what happened.
I usually use this earphones. I never had a problem. Maybe that background noise is causing a lot. Raju, is it okay to continue?
Ma'am, it is not right now. Your voice became very low.
Is it something to do with the laptop voice? Nothing, right?
The laptop voice is high, right?
No, it was low. Because, is it better now?
Yes, it is better now.
Okay, so the laptop voice was kept very low. That might be the reason.
But we are still having that background voice.
Sorry?
We are still having that some background noise coming in.
Yeah, because I stay very close to the road and there is a big apartment construction on next building. So I try to shut down the door. Just
Dr. Sreedevi?
hello?
Yes, we can hear you.
Yeah, I just closed whatever possible doors. So let's see. Okay. So next we will go through a few patient scenarios so that we'll able to understand how to deal with each scenario. So this will be a story about a 56-year-old male with carcinoma colon. and he is vomiting continuously. So we'll be talking about the same patient going through the different situation. I know that the receptors and everything together will be too much to understand in one session, but I'll try to apply it in the case study so that you will be able to relate at least something. So the first scenario is that this 56-year-old male with carcinoma, he tells vomiting. On asking further, he told, I have chronic abdominal pain also, and I have feeling of fullness. There is a distension, and whatever I am vomiting is green in color, and I have not passed stools for at least a week. So this is scenario one. So what would be the suggestions from your side? Which would be you don't need to talk about the receptors, but yeah, how to move forward. Yeah, someone has answered, right? This is about bowel obstruction. We'll be dealing in detail about bowel obstruction in the next session, but very briefly, Raju, your mic is. So in this situation, usually the patients will feel okay
most of the time, but they may have nausea depending on the site of obstruction. Sometimes people will tell you that I feel much better after vomiting. And sometimes they may tell you I'll take at least an hour after the meal to vomit. Usually they will say epigastric pain or discomfort. I'm rushing through this because we have a detailed session on bowel obstruction next week. Usually the stretched receptors will act. There usually deals with the serotonin release from the enterochromatin cells. So we have to use the vagal stretch, the serotonin receptor blocker or urocinin 1 blocker. The drug would be usually a combination of steroid and a prokinetic and drugs to reduce the gastric irritation. And if a particular drug is causing the obstruction, stop the offending. So the same 56-year-old male with CA colon has persistent vomiting, and we know that on further asking, I had chemotherapy 3 days back, and today I have come to daycare for the third cycle of chemotherapy. So what would be the reason for this vomiting? And what are we dealing with here? He had vomiting 3 days ago, and he always received chemotherapy. Today he has come for chemotherapy, and yeah, exactly. So it can be cerebral cortex. It is not. It is only the cerebral cortex I'm telling, but most probably, it would be cerebral cortex, and he might be dealing with anxiety or memory-related nausea and vomiting. And we have seen he has underwent chemotherapy 3 days ago. So that might be due to the chemotherapeutic agents acting at the CT set. So the drug-related vomiting, the first scenario, the drug-related vomiting.
And for the second scenario, where he has come for chemotherapy and having nausea and vomiting, we have to deal with the anxiety and memory. The drugs commonly used when the CTZ is involved would be ondansetron or granisetron, usually given for 3 days after chemotherapy. If you are dealing with anxiety-related nausea and vomiting, then it would be lorazepam, anywhere from 0.5 to 2 milligrams. Again, another the same patient telling you that I have severe nausea and vomiting, along with severe headache and weakness of right half of the body. So what are we dealing with here?
Cerebral metastasis.
Exactly, sir. So there is a raised intracranial tension. So we know that there is a raised intracranial tension, the drugs. So here, so the point is that here you can't just give ondansetron or metoclopramide. It is not going to help the patient. So if you know that it is raised ICP or meningeal irritation, then we have to use the drugs to reduce the raised ICP, mannitol or steroid. Or sometimes they undergo, if it is the cancer-related ICT raise, if it is due to brain mets, they might be undergoing radiotherapy. The fifth scenario is that the patient, so we are here talking about the same patient with vomiting, with vertigo and head movement causing vomiting. So here it is very easy. You might be seeing a lot of this, which is movement related. Or,
vestibular dysfunction.
Yes, sir. Thank you so much for the response. So it is vestibular or motion related. Here we have to give histaminic or muscarinic blockers. The commonly used, the commonly used drug we all heard in the promethazine drug we all very commonly use. Very rarely, morphine can also, some patients will tell you after starting morphine that they have motion related nausea and vomiting. So the next scenario that we have started this patient on morphine, 10 milligram every 4 hours, and he's telling, I have early satiety and bloating sensation. So, sorry, I just skipped this slide. Yeah, drug-related nausea due to morphine. So it is not just drug-related in terms of morphine, it is also due to the decrease in the gastric motility. So the important part here is to give a prokinetic also. The main action would be to reduce the kinesis. It will decrease the peristaltic movement. So here we have to, the choice of drug would be either haloperidol or metoclopramide. You can start with 10 milligram 8-hourly or 6-hourly. Haloperidol, we need only a very small, you don't need to give both, okay, either haloperidol or metoclopramide. And if it is still not under control, we can always think about switching the opioid, which is very rarely needed. Usually it will get controlled. So the same patient is telling that I have nausea and vomiting plus increased pain over the right upper abdomen. I have continuous pain and this pain increases on deep inspiration and I have loss of appetite.
Yes, hepatic metastasis also.
Yes, sir. Right. I'll just put the chat also. Yeah, so there can be liver capsular enlargement. So here we can always use, usually in the palliative care setting, we will be using steroids so that there is decrease in the peritumor edema and the symptoms will be of great relief. Again, the same patient has a history of heart disease and he is on aspirin, 325 milligram per day with symptoms of epigastric pain. So here you can't think about metoclopramide or diphenhydramine. So you may have possible gas. Sorry. Yes, sir. Exactly. So we have
Pantoprazole is better.
Yeah, any PPI, any proton pump inhibitor you can give here, whichever is I think the preferred drug, but it should be a PPI. Yeah. And the last, I think probably this is the second last. Sorry. So there is a history of fever and diarrhea along with vomiting. So here we are dealing with
infection.
It's infection. So here we have to treat with appropriate antibiotics or antivirals, whichever we think will be the cause. And the last scenario would be, I have given this clue
during the presentation also, the patient is having sore mouth, loss of taste and anorexia, unable to eat anything because of bad taste in the mouth.
Oral hygiene.
I think there's something, yeah, there is one answer in the chat, it is oral thrush, so probably it may be due to the candidiasis infection. So here we have to treat with antifungals than giving antiemetic. We don't need antiemetic at all here usually. Just with good anti-fungal therapy, this will subside on. So I went through all the scenarios just to make sure that we have dealt with the same 56-year-old male with carcinoma colon. His diagnosis says everything is similar, but the same patient can have nausea and vomiting due to multiple reasons, right? So just because that this patient is CA colon, you can't just rely on one single antiemetic all the time. So even if the patient with the same diagnosis is coming, you have to think which can be the pathway involved. If so, which will be the receptor there? If so, which will be the blocker that we can use that is available in our country, which can be used, and appropriate. That is why I just quickly went through this 10 scenarios.
This mechanistic approach. That means we are identifying the likely cause of nausea and vomiting. We are looking for what can be the reason, and then we are thinking about which pathway will be involved. And again, next, if it is this particular pathway, what is the neurotransmitter receptor involved in this pathway? And if you know the receptor, then you need to understand which is the strongest antagonist that can be used so that we can get good antiemetic effect. And the next point would be to choose a route of administration. Usually we may need to exclude the oral route because if the patient is vomiting, you can't just administer an oral drug. So we have to choose the route wisely and titrate the dose carefully and review the patient. So the small example would be when you give a prokinetic, you really and you are not sure whether there is a complete obstruction, you need to review very clearly and frequently. And antiemetics usually, like in pain medication, you have to give regularly, not SOS. Very rarely patients will tell that only in the morning once I vomit, then it is fine, but otherwise it has to be given regularly. And you have given antiemetics, the systems are still the symptoms are still persisting, then again you have to go back and think, did I overlook any of the cause? Is there any other alternative pathway that I need to think about? Do I need to combine some of the antiemetics? Sometimes we need to combine antiemetics. So do I need to combine antiemetics so that for a better result? So we need to go back and think again, review the patient again, ask for the symptoms again. If combining antiemetics, we need to think whether this particular combination has any advertent drug reactions or interactions. So we know that any of the antimuscarinic agent or antihistamine can counteract the effect of a prokinetic agent. So when it is okay to combine, sometimes we may need to combine, but just make a sensible combination. So that is about the nausea and vomiting presentation. I can take up a few questions. I know that it is quite helpful for dealing with a lot of receptors and everything in the afternoon session, but we don't need to by heart all this. We just need to understand today's purpose. We just need to understand that a same patient can come up with various pathways involved, and why it is so important to understand which pathway is involved, which receptor is involved, and to choose appropriate antiemetic than just giving any antiemetic. So that is one thing that you can take from today's session, and you can always go back to the presentation for receptors and everything. And over a period of time, when you start relating all this, then it becomes much more easy.
Okay, thank you, Sreedevi. So there is a question in the chat box. Which is the most effective antiemetic?
So I think you yourself after the presentation should tell me, is there a single antiemetic which we can say that it is the best antiemetic, or is it depending on something else?
So we don't have a choice of antiemetic for many situations. So each situation we need to have a specific antiemetic depending on the pathways involved and the receptors involved. So we cannot say which is the most effective antiemetic. If you ask me which is the most effective antiemetic for opioid-induced nausea and vomiting, okay, I would tell it's a D2 receptor antagonist. So haloperidol, metoclopramide, or something like that. Which is the most effective antiemetic for acute chemotherapy-induced nausea and vomiting? It is 5-HT3 antagonist. So it depends on the situation. Okay. Any more questions?
So I have noted the point in the chat that slide should not have more than 5 to 6 lines. I think for the next session onwards, I would make sure that it is more readable for everyone. Thank you for that suggestion.
Anybody? Okay. I don't see any more questions. That doesn't mean that there are no questions, but it may take some time to digest the information. Okay. Anyway, it's 4 o'clock. We will move on to patient story. So the most important thing is we have to differentiate between nausea, vomiting, retching, hiccup. These are some symptoms which the patients may tell you, or we they may mislead you. So it is important for us to understand what is happening. And whenever we hear about nausea and vomiting, don't think of a drug immediately. We have to ask the history further and explore what is the reason. Find out the reason from the history itself, if possible. And then we can actually come to a conclusion that it could be this. It may be because of the gastric stasis, or it can be due to increased intracranial pressure, or maybe due to gastritis. So come to the conclusion and then think of medication that can help the patient to relieve the nausea and vomiting. But many a times the etiology of nausea and vomiting is multifactorial. So we have to also think about that. Uh, Constipation is another important factor which we usually neglect, and even super specialists may tell you, oh, that's okay, constipation, no problem, it will not cause anything. So uh, it's very important because it can also cause stretch receptors to get activated. So there are many antiemetics which are available in the market. And another important thing is we have to select the route of administration in nausea and vomiting. So if the patient has continuous nausea and vomiting, you have to select either subcutaneous or intravenous route. Otherwise, if you give administer orally, the patient will vomit immediately and it will not have any impact. So thank you, Sreedevi. We will move on to the patient story, which will be presented by Dr. Dattaram. Dr. Dattaram.
Yes. Hello.
You can, yeah, yes, sir. You can.
Can you hear me?
Yes, we can hear you.
Yeah. Good evening, everybody. I am Dr. Dattaram Desai. I am from Goa, and I am a family physician in a village. At the same time, I am working in an organization called Dilasa, where palliative care is being given for last 2 years. Hello.
Yes.
Yes, sir, we can hear you.
Okay. I'm happy that today I could hear Dr. Sreedevi Warrier, who was working in our palliative care center for almost, I think, 6 months. Today's case is a 69-year-old female. Her diagnosis was carcinoma of head of pancreas with nodal disease and metastasis in the liver, diabetes with hypertension. Her presenting complaints were abdominal discomfort and pain, nausea and vomiting, and constipation after diarrhea. History of illness: 69-year-old female, a known case of diabetes and hypertension on treatment for past 20 years. She underwent total knee replacement in 1992. In 2019, she had history of fall and hip replacement surgery was done. In October 2020, patient had nausea, vomiting, and jaundice, and investigations revealed that patient had carcinoma of head of pancreas with liver metastasis. Percutaneous transhepatic biliary drainage was done, and jejunostomy was done. A surgical intervention was not possible. So Whipple's procedure, biliary bypass and jejunostomy was done on 7th of November 2020. The symptom management was done in the hospital and she was referred to Dilasa for palliative care on 10th of April 2021. On examination, she was afebrile, pulse was 70 per minute, blood pressure was 128/60, no pallor, cyanosis, clubbing, icterus, no lymphadenopathy. Respiratory system was clear, air entry was equal on both sides. Cardiovascular system normal, CNS conscious and oriented, per abdomen soft, non-tender, and the drain was in situ. Treatment and significant investigations. Operation theatre findings on 7/11/2020. Lesion in the head of pancreas with gross inflammation of the surrounding tissue and edema. Lesion is infiltrating into the insertion of middle colic vessels. Nodal disease present at the mesentery. In view of the nodal disease, declared inoperable and proceeded with bypass. Multiphasic CT scan of abdomen was done, and there is a long report in which I can see that liver is enlarged in size. It measures 19.5 centimeters in span, shows diffused severe fatty infiltration, an area of heterogeneous enhancement measuring 5 by 5.1 by 5 centimeters. And it's a lengthy report, but the conclusion is that she has got CA head of pancreas. Going further, treatment and investigations. On 5/4/21, serum creatinine was 0.53, serum amylase was 24, serum lipase was 10, serum calcium was more than 1000. In liver function test, bilirubin total was 0.96 milligrams per deciliter. Direct bilirubin was 0.84 milligrams. Bilirubin indirect was 0.12. SGOT AST was 97 international units. SGPT total proteins was 5.2 grams. Serum albumin was 2.3. Serum globulin was 2.9. And AG ratio was 0.79. As far as her psychological aspects were concerned, she was a teacher previously and retired now. She has got one son, and she is more worried about his marriage. And her husband's health is also not good. He has got diabetes with hypertension. The medications she has received is diabetic diet, joint care, drain care. Medicines given in the hospital were Ciplox 500, Pan 40, paracetamol, Econom sachets, Ursocol, Thyronom 12.5 micrograms. Her main concern is pain in abdomen, loss of appetite, vomiting, and depression. In summary, 69-year-old female suffering from carcinoma of head of pancreas with nodal disease, with diabetes and hypertension, after surgery is having abdominal discomfort, loss of appetite and vomiting. Psychologically, she is worried about her son's marriage and husband's health. Now, the points for discussion are how to relieve her of her abdominal discomfort and pain, medicines to stop vomiting and improve appetite, psychosocial aspects, that is depression. In Dilasa, we gave her tablet morphine 2.5 milligrams TDS to start with for pain. For constipation, we gave her Bisacodyl 2HS, IV fluids for dehydration, tablet amitriptyline for pain, tablet Perinom for nausea, and tablet Zolfresh for sedation. She was also given Perinom infusion 60 milligrams over 24 hours. So that is all. The case is open for discussion.
Hello.
Thank you, sir.
Hello, Dr. Sunil Kumar.
Yes,
Good
sir.
afternoon, Dr. Kale from
Good afternoon,
Nagpur.
sir.
Here the morphine dose is highly inadequate. So they should titrate morphine with injectable morphine and come to a dose where she can be stabilized. So 2.5 milligram TDS is the too low dose, and morphine titration has to be done by injectable as per your advice. This is first comment. Secondly, rest of the symptoms can be managed once we titrate her with morphine injectable. And main concern is pain because she is incurable. So the pain should be the main concern. Nausea, vomiting can also be taken care. Thank you.
Okay, thank you, sir. What you told is absolutely right. But one of the problem would be many centers may not have injectable morphine. So they need to use oral morphine.
And with oral morphine as well. We are doing presently with oral morphine only. But the dose is highly inadequate. It is inadequate.
Yeah.
It was increased later on, sir. It was increased later on.
It should be increased because she is an elderly person. She must be around 50 kg. So even at 5 milli, it can be 10 milligram also. Can be given 1, 2, 3, 4, 5, 6 times. And I think it will settle with that.
Later on, the dose was increased to 5 milligrams 4 times a day, 4 hourly, and night dose was increased to double. Initially, it was started with 2.5 milligrams 3 times a day.
Now she should settle. If it is not settled with that dose and you don't have injectable morphine, you can increase the dose by titration from 5 to 10, and that should settle. Thank you.
Thank you, sir. Anybody else want to comment on morphine and pain relief?
I want to know, as per Dr. Sreedevi's lecture, what receptors are getting affected here? Is it GIT, liver metastasis?
So, can you tell us more about nausea and vomiting? How many times and what is the content of the vomiting?
Of?
What is the content of the vomiters?
Content of the vomiters is whatever she used to take. Mostly she used to vomit with the fruits. Whenever she used to have fruits, she used to vomit. But she could sometimes retain vegetables. That's what she was telling.
Oh, okay. So, is it only with fruits or even other meals?
No. It was with other meals also. But what she told us, what she was telling is that she could tolerate vegetables better than fruits. That's all. It was not a very important thing, like. But she used to vomit everything.
Okay. Is it big volume or large volume or small volume?
Small volume.
How many days?
I beg your pardon?
How many times per day? Any idea? Approximately?
She was vomiting constantly, like without, I mean, I cannot tell you exactly how many times.
Okay.
Whatever she took, she used to.
Dr. Sunil Kumar, hello. Dr.
Yes,
Sunil Kumar.
Yes, sir.
In case of head of the pancreas or pancreas malignancy, there is a gastric outlet obstruction, GOO, because that is pressing onto the duodenum, and that is one of the cause of mechanical, partly she is vomiting, and that's why there is a partly mechanical obstruction which is known as gastric outlet obstruction. So that can be solved, of course, by intervention. After a gastroscopy, we can make out whether there is anything blocking, and if it is so, the stenting can improve that. Instead of only giving antiemetics, because the correctable has to be corrected according to the law. So this is the better solution, because I have seen in case of gastric this thing in the head of pancreas, there is a gastric outlet obstruction. This is another solution.
Okay, thank you, sir. I see there are some suggestions in the chat box. One is maybe a nerve block for pancreas, and avoid fatty foods.
Okay.
And another suggestion is gastrointestinal. Okay, Sreedevi, would you like to take?
One thing before Dr. Dattaram was telling us, seeing him, I became so happy because, as he said, we were working together for a few months. So nice to see a presentation, and very coincidentally, at the same day, I could be a part of it. And sir, I would like to ask, even with perinom infusion and everything, is she still having vomiting? Is that what you are telling, or is it a symptom control?
No, Dr. Sreedevi. After our perinom infusion, she became better. And she was very much worried about her son. So she went home on 2nd of May and expired on 26th of May. But she was feeling better with perinom infusion.
Yeah. So I think from whatever you presented, I felt it is more like maybe an obstruction, impending obstruction. And you have done with the good use of laxative, combination of laxative, prokinetic, and opioids.
Yeah.
And I understand that with the infusion. So that is a very good point. Sometimes intermittent medications may not work for controlling nausea and vomiting. Very often they may need continuous infusions of antiemetics, very commonly. So that I hope have worked for her. So I would not actually change anything. This would have been what I have done also, because she got a good relief with the infusion then.
Sir, I saw that during your presentation, the serum calcium is 1000. Was by mistake it is written as 1000, or is it something else?
Sorry, sir. I couldn't get you.
The serum calcium, you have written it as more than 1000. Is it some other enzymes, or I think it's probably some other enzymes, not serum calcium.
It is by mistake. It can be 1000.
Yeah.
Serum calcium is never more than 10.
It can be. Yeah, it must be.
Yeah.
It is by
Okay.
overlooking.
Yeah.
Sorry. Okay.
Anybody else has any more opinion?
Sir, if it was not being controlled with metoclopramide, then I would like to ask the patient more about, like, is she feeling relieved after vomiting all the contents out? Like, she feel fullness, and sometimes after vomiting they feel relieved. So that means there is pooling up of lot of secretions, and then I may think about some other measures to relieve that pressure and understand where exactly the obstruction is. So I think we'll be talking more about that during the next session on bowel obstruction. But if it was not controlled with metoclopramide, then I would go much more deeper, like asking more about like, was it giving relief after vomiting? Was it like, sometimes they may say initial first few spoons I was okay, but the moment I take more than 3 spoons, then I start having distension and then vomiting. So then I would ask more questions like that. How much you can tolerate at a time? Is it the consistency of the food, or is it like acidic fruits causing vomiting? Because the vegetables might be really bland. There is no sour or sweet taste. So that is one thing that. So I would ask more questions if it were not controlled with metoclopramide. And what is the volume of the vomiters? Is it like too much volume? So then we need to think drugs which should reduce the amount of the volume of the vomiters, to make it more drier. So so that would be the next step if it was not being controlled.
Anybody else? Okay. So as Dr. Kale's opinion, and that you have already done, increasing the dose of morphine. And probably if this patient had severe pain from the first instance onwards, then we would have started him on with at least 5 milligram morphine per hourly if there is no concerns of renal failure or things like that. And we can always titrate up or down depending on the toxicities of the patient. So the nausea and vomiting is probably due to probably because of some partial obstruction, and as Dr. Sreedevi told, here the route of administration is more important, as I told you earlier. So injectable metoclopramide, we usually give it subcutaneously. So subcutaneous or IV route is should be selected, otherwise the patient will vomit out. And the patient was vomiting frequently, so we have to give it either subcutaneously or intravenously. And maybe another thing I think which we can do is trying to add an dexamethasone steroid, so which is a broad spectrum antiemetic in many situations. Here, as we suspect the compression or from carcinoma of the pancreas or nodal met, something like that. So we can reduce the peritumor edema surrounding the tumor, thereby reducing the compression. So that might be one of the things that we can add here.
Sir, how much dose dexamethasone?
Okay, usually dexamethasone in the range of 12 to 16 milligram once a day.
Injectable.
Yeah, injectable dexamethasone.
Right. Thank you.
And there is
intravenous
yes.
dexamethasone.
We can give subcutaneous also. Dexamethasone can be given subcutaneously or intravenously.
Okay. Divided doses.
No, once a day.
No, once a day.
Once a day. Once a day. 24 hours. Once a day.
Yeah. Okay, and I see there is a question in the chat box. What are the features of depression? It seems to be more of anxiety, from Dr. Anita Chandana. Sir, can you talk about this patient? What are the features of depression?
She was all the time looking worried and thinking about her son. When the counselor talked to her, she started crying. And she said that she is more worried about her son's marriage. He should get married before I die. So that was the depression she was having. We gave her, just a minute. We gave her amitriptyline, 2.5 milligrams HS, and Zolfresh 10 milligram for that depression. Zolfresh for sedation. Was it okay?
Amitriptyline थोड़ा ज़्यादा थे. Amitriptyline 2.5 will not work. It should be at least
25, sir. I think
10 to 25. Between 10 to 25. She's an adult. Either 10 or then you can increase after 3 days to 25. Amitriptyline.
So before going on to the treatment as such, so any other participant has any points regarding this features of depression in this patient?
I think it was more of an anxiety and no classical symptoms of depression.
Okay, Sreedevi. Okay, doctor. Yes, Dr. Vinagaran.
Yeah. Psychotherapy could have helped.
Hello.
Okay, Sreedevi, what's your opinion?
Yes, sir. Are we talking about whether it is anxiety or depression, or if it is
Yeah.
depression that
Yes,
we
yes, yes.
Yeah.
Yes.
So
Yes.
yeah, so I think there are a few questions that we need to ask, and that should be like, if it was anxiety, then you will aggravate the things when you give an antidepressant. So it is very important to ask a few questions to differentiate, especially the sleep pattern. Like, is it early loss of early awakening from the sleep, or is it difficulty to fall asleep, a loss of interest, or is it more like she's worried all the time, so that is unable to start sleeping, or is it because that I don't feel interested thinking about all this, I totally feel disinterest. So it's very important to ask those few important pinpoint questions to understand whether it is anxiety or depression. Then again, I would go the cause, why she is anxious and why she is depressed, and then probably then we choose the appropriate drug. Not like, if it's the other way around, you may actually, so the patient with anxiety, if you give antidepressant, or is it other way around, it actually going to worsen the sleep pattern and everything. So that would be one thing I would suggest.
Very right, madam.
Feel that the patient looks depressed because she might be thinking and worrying all the time, but that may not be actually depression. So a few questions to understand whether it is anxiety or depression would be good.
So the clinical depression should be differentiated from what we see from the patient. So that's why Sreedevi is telling that some questions need to be asked, and some of the features, as she told, we had that. In addition to that, we can also ask about the mood. Then uh, uh, other features of depression, by which we can assess depression in cancer patients, are hopelessness, helplessness, and worthlessness, which should be out of proportion to the disease that she is having. So any patients with advanced malignancy will have hopelessness, helplessness, and worthlessness. So we should assess whether it is out of proportion to the present situation, and anything, any attempt for suicide or thoughts about suicide. So those are some points which we should ask from the patient to find out whether is it a depression or something else. And if it is depression, then usually nowadays psychiatrists use SSRIs, selective serotonin reuptake inhibitors like citalopram or escitalopram. And the tricyclic antidepressants like amitriptyline, it would need higher doses. So better drug would be SSRIs, maybe 10 milligram escitalopram. And if here it seems maybe more of anxiety regarding the son's marriage, whether I could see it before that, am I going to die, things like that. So maybe one of the benzodiazepines like clonazepam would help the patient. And if the anxiety is persisting, then also the drug of choice would be SSRIs in persisting anxiety. So these are a few things which I want to tell. Anybody else want to make any more comments?
Thank you, sir.
Hello.
Yes, sir.
Dr. Kale from NAC. It is better to get it evaluated by a psychiatrist as per Dr. Datta's lecture yesterday, because it's very difficult for us, all palliative care physicians, to understand depression and go in detail. So it is better to have a psychiatrist to opine on that, and because the depression and anxiety can be intermixing. So psychiatrist's opinion is better than our palliative care physicians. Thank you.
Thank you, everybody.
Okay. So Thank you. I think we can wind up the session for today. So thank you, Sreedevi, for that wonderful class on nausea and vomiting. And thank you, the Taram sir, for a patient story, good patient story.